Hello, everybody. My name is Rich. I am the CEO and co-founder of Aboard. You're probably wondering where you are. You are in the offices of our little AI startup called Aboard. You're probably wondering what we do. Maybe you're not, but I'm going to tell you anyway. We leverage AI to ship solutions, ship tools, ship apps to organizations and businesses. And we do that by working with you. We've built some really magical tools that allow us to work really, really fast. But we also don't have illusions about how AI can be a runaway train. And so we get to know you, learn about your organization, learn about your needs, and we use AI to ship really quickly, really impressive things. That's what we do. I'm going to share one little case study, a little story around our work with the Child Center of New York. The Child Center of New York is beyond New York. It's clinics in the Northeast that provide counseling services for kids and families. And one of the challenges they have is that as an organization, they can't tell which clinics are running well, where the problems are. And they approached us and they said, can we gather information from all these clinics to a central place and help us make better decisions and also put our energy and focus to the clinics that need our help the most. And so we started working with them to put together a platform that looks like a dashboard. Dashboards suck for a lot of people. They're hard to digest. They're hard to make decisions off of. And so we wanted to build a platform that allows people who are not technical, who are not used to looking at data all day, to make better decisions. And so it looks like a normal charts and graphs dashboard, but it also has actions that clinicians and operators can take to improve how the clinics are run. It even has the ability to just ask questions. How are we doing? Is the visit time too high, et cetera, et cetera. And it has an interface where they can talk to the data in effect. That's the end of the bait and switch pitch that I was going to give you guys before this panel starts. Talk to us. I'm around. I'm Rich. I have a name tag. And I'm going to turn it back over to Paul Ford, my good friend, president and co-founder, and moderator.
Thank you. Hi, I'm Paul. Welcome. We are trying really hard to make a community space for New York City to talk about artificial intelligence and what is coming down the pike. Partially because I don't think we're ready, and I feel that the Bay is going to pick our pockets yet again. And I'm coming out of media from in my earlier part of my career, so I've seen it happen. And so I'm paranoid, and I want people to meet up and get ready and be defensive and smart about this technology. So we've done a bunch of events. This is the biggest one so far. It was a great turnout. Thank you all for coming. I know it's cold, but this is a wonderful and august group of people. I am not a health tech person. I'm a journalist, though, in a past life. So I'm going to switch into moderator mode, and I'm going to introduce some folks, and then they're going to talk, and I'm going to just ask some questions, and I think we'll talk for like about a half hour, and then we'll open it to questions, and then people really should feel free to mingle. Welcome, and thank you very much to our panelists here. I'm going to just quickly introduce people, and I'll start with Dr. Kamal Menghrajani, MD, MS, who is an oncologist, computational biologist, and entrepreneur who served as the first ever oncologist selected as a White House fellow. She was the assistant director, that's under the Biden administration, just so everybody can calm down. She was an assistant director for cancer innovation and public health at the White House Office of Science and Technology Policy. Today, she's an associate physician at Mass General Brigham, as an oncologist and a clinical lecturer at Harvard Medical School. And then Dr. Chethan Sarabu, who is director of clinical innovation at Cornell Tech's Health Tech Hub, AI and informatics consultant at Open Notes Lab, and co-founder of the Climate Health Innovation and Learning Lab. So he's focused on patient empowerment through AI and recently co-authored a New England Journal of Medicine Catalyst paper on sustainable health AI. And then my old friend, but august presenter, veteran entrepreneur Erynn Petersen, also my former mentor. Thanks. Glad to return the favor. Not former, probably still. Erynn is the CEO at Emme, which if you don't know it, it's a great startup. Go take a look and see what they do. And it's a healthcare technology company focused on women's health and more broadly, kind of, you'll talk about it, but dealing with insurance using AI and doing all kinds of stuff. And so we'll talk about that in a second. Previously, the CTO at Simple Health held senior tech positions at the Department of Defense and at Drizzly. which is a hell of a combo, actually. And really a remarkable background that we'll only be able to get into a tiny bit across healthcare and national security and consumer tech and all sorts of stuff, and has great war stories about mid and late 90s Seattle. And so, but I'm going to just ask you all just sort of quickly, like, what are you doing, let's say with AI? Like, what is artificial intelligence doing in your day-to-day? What are you building? And let me start with you.
Great. Thank you so much for that warm welcome and great introduction. And thanks to the folks here at Aboard for hosting us tonight. Really appreciate their efforts to build a stronger community here focused around AI. So in addition to being a physician, I'm also the medical director for AI at Doximity. Some of you may have heard of it. It's a company that provides free tools to physicians to help improve their workflow. And I've been helping them think through how they can actually use AI. So they have a couple of products, a scribe, a competitor to Open Evidence. And it's been really interesting as the physician in the loop, providing oversight, helping them think through how to make tools that actually will work at the point of care. And then as a teaching physician, it's been interesting to see how these things have rolled out in the clinic, what residents are doing with them, and how it's impacting the way that they think. And I'm sure we'll get into more of those details throughout the discussion.
We will. Erynn.
I'm Erynn Petersen. I run a company called Emme, and we're using AI to figure out how to make healthcare more affordable for people. So most people's primary cost expenditure comes when they buy their health plan, which determines all their costs thereafter. And we use AI to save money upfront on the healthcare plan and then save money on every service afterward. So we're really trying hard to harness this technology to make healthcare more accessible for people, and also, by the way, to make it easier for physicians. If we can pay physicians faster, we can pay them with less paperwork, and you don't really need it for anything under $1,200, then everybody goes home a lot happier.
Hi there, my name is Chethan Sarabu. I am a pediatrician, and I've been working with AI in healthcare in a couple of different facets. Back in 2018, I was in Silicon Valley, joined an early stage health AI startup called Doc AI. So it's really in the weeds of building AI tools, more in the computer vision, machine learning space. And I spent 7 years in Silicon Valley, been in New York now for 3.5 years. I'm from the East Coast. And I could definitively say that New York is the best place and number one place for healthcare technology, for health AI. This is the place. It's I'll just leave it at that. Part of it is, I think, and we'll get more into it later. I'll go into that later. I have a lot of reasons why. The things I do with with AI and healthcare, broad span. So as a practicing pediatrician, I'm using ambient scribes in practice and getting into the nuances of how to make sure they work well for children who are often left behind by technology. I also teach a lot. At Cornell Tech, I teach executive MBA students. Just today, I kicked off some different health AI projects with Cornell Tech master students. I also, as was mentioned, do a lot of work at the intersection of climate change and health, looking at the environmental footprint of AI. Started this organization, Chill, and then also part of this nonprofit called Health and Climate AI, which is kind of looking at both how we use AI to address the health impacts of climate change, like extreme heat through hackathons we organize, as well as understand and address the environmental footprint. I think New York has some really compelling opportunities here with initiatives like Empire AI. Finally, I also do have a startup called OpenHand, my cousin, that's been exploring patient-facing AI tools around cost and providing tools like scribes for patients and exploring what that looks like. And I think that category has been really exploded in the past few weeks, at JP Morgan, when OpenAI and Anthropic announced how they're really getting into healthcare fully. So excited to delve into all of it.
Great. Thank you all for being here and giving your time. It's great. And I came up with 4 M's. We're going to talk about 4 different things that start with M, but I'm not going to tell you what all 4 are. Yeah, so you got to wait.
We don't even know.
Yeah, exactly. I didn't know. No, you guys, you're on your feet. You're doctors. You're pretty much a doctor at this point. Like, you should be able to handle this. So I think actually the one thing, I'm like, let's just start with the kind of like metrics and measurement, right? Like because I think especially healthcare is a very different relationship to AI, and it's a very positive relationship in a lot of ways, because I'm coming from the culture industry or even from technology. People are like, what is this mess? And there seems to be more of an approach to actually measuring success, understanding what's going on, getting rid of pajama time and like sort of ambient documentation stuff, all this stuff. And so I think, like, what are you looking for? How do you measure a success? Like, let's start there and then dig in a little bit. So let's keep going, this way. This is a good direction. I like this direction.
Almost like I'm never
Oh
sitting
my
here.
God.
Yeah, I know. Sorry.
Oh, it's the worst seat.
Yeah. You could just scooch over and nobody would say a word. Yeah. There you go. All right, Erynn.
Not seat.
I think. No, yeah. I mean, I think it kind of depends on like what it is that you're going for, right? Obviously, like I'm also a clinical researcher, and we think a lot about like what is the endpoint, what is the outcome, and then that's how you figure out, oh yeah, this is how we're going to design our study to get there. A lot of people talk about AI shouldn't just exist to exist; it should exist so that it solves a problem. So I think in terms of what the metric is, it's very relevant to what is the problem that you're trying to solve. And so, I'll give an example. As an oncologist, we put a lot of patients on clinical trials. And over the years, I've seen a lot of these clinical trial matching services come about. And it's basically an AI-powered tool. And instead of searching the internet or clinicaltrials.gov, a patient can use the tool and say, I have this disease. Help me figure out what clinical trials are within 100 miles. Now, you could think, okay, the outcome could be number of patients who end up on a clinical trial, but that's not necessarily the right metric. The right metric would be number of patients who end up on an appropriate clinical trial, and that's a lot harder to measure. Things are growing in that space. Things are getting better. But when it initially started, actually a lot of these companies were funded by pharma, and pharma was trying to find a way to increase recruitment to their clinical trials. And whether or not it was the best option for the patient was sometimes irrelevant. And so thinking about what the metric is actually really important, because even that kind of subtle difference can make a really big impact in healthcare, especially in oncology. So getting the metric right is really important, and then continuing to shape AI tools so that they more closely approximate the outcome of interest is also really critical.
Yes, that's great. Actually, like that's kind of what I was hoping for. Going over to you, Erynn, what are your metrics? What are your
We have a bunch of, we're a startup. We have very clear metrics. The first one is how much money are we saving patients? That's our most important. We measure it every day. The second is how many times are people coming back? So we already have more than 10% of our users, we've only been live for 2.5 months, have come back more than once. So for more than one service, we're saving the money. The third is, are people getting care that they otherwise weren't getting? So we already have 2 patients, 2 members who had, actually one of them had canceled their appointment with us, and we followed up. We're like, no, we'll just do this for you. And they were going to skip their care. They were not going to go to the doctor because they thought they couldn't afford it. And we showed them, no, you can afford it. We helped set them up with a plan. We helped set them up with care. And they are now getting the care they needed. And then the third metric we track, and this is really important, this is purely technology, is are we driving down the cost of every single transaction we touch? So for those of you, I'm trying to guess how old people are in the room, a lot of people don't remember that early on. One of Amazon's metrics was, how do we make it as cheap as possible for people to get the book that they want to find and buy? Because they believed that if they drove down the cost of accessing information and data, more people would be able to get books. And by the way, it would be harder for people they malintent to compete with them in the marketplace. So we firmly believe that if we can drive down the cost of providing our services, we can make it easy and affordable for people to find the care that they need.
Chethan, over to you. Metrics.
Yeah, so the first place my head goes to is that quote, I forget who it's attributable to, but it's not all that can be measured matters, and not all that matters can be measured.
That was me.
Okay, yeah. Right, so I think it's a really important starting point, because we often, for example, when we talk about things like documentation burden and pajama time, where clinicians are spending a lot of time writing notes, we optimize. Health systems are like, okay, we gotta help clinicians get notes done quicker. But that's only looking at half the story. No one looks at, on the other side, When I'm a doctor, especially working in if I'm in an inpatient setting and I'm taking care of a patient who's been in the hospital for weeks, there's so much information there, and I have to figure out, which note. There's people who take the time to write good notes would help me figure out what's actually going on. The person who took the time to write that note is penalized by the metrics of the system, right? We don't actually value good quality notes. It's not a metric that gets paid for. So you have to realize, everything in our healthcare system, from the data that's there to what's penalized and reimbursed, shifts what gets emphasized and put in. So that's kind of one of the starting points I think of. One other thought, kind of orthogonal to that, I think when we think about measuring AI and evaluating it, there's a lot that the FDA has done for things like predictive models, things like sepsis models and computer vision tools that have more clear parameters. I think in the world of large language models, it's a lot trickier, and the FDA has not necessarily come out and said this is exactly how they should be measured. We have seen this advancement where early on, when you looked at, whenever there was a new kind of update to GPT or ChatGPT and so on, it'd be like, okay, now it can pass the USMLE tests and do this well. People realize that those benchmark tests are not great. That's not what the real world of medicine is like. And so better benchmarks have been created, like Stanford put out No Harm, OpenAI put out Health Bench. But I think one of the key issues those metrics miss is that they only rely on clinician evaluators. I think we actually need to bring in patient evaluators, especially if you look at and this is a lot of the work we do at Open Notes. You need both. You need both patient and clinician evaluators. It's particularly important in the context of the announcement of ChatGPT for Health, right? If you want to test how well ChatGPT for Health works in answering the question of why am I dizzy, right? The way patients may ask that question may differ than how a clinician would ask that question. And so we've done some work in publishing and how do you bring patient experts into creating benchmarks?
I want the three of you to offer some advice to a early career person who has just realized that they've been measuring the wrong thing on this big project that they're on. And they need to go tell their boss, something's got to change, right? This is the scariest moment. And then you spend 3 years measuring the wrong thing and you hope it all works out for you. But let's change that. What do you do? How do you reset this situation? And I don't know. I want to know. You seem smart. Smart group. Think about it for a minute. It's okay. Everybody's got time. Then go get some cheese. You have nothing but time.
Is this even a thing right now?
I don't know.
No, really. I don't think this is a thing the way it was a few years ago.
Explain that. I'm confused. What do you mean?
Right now, we're in this sort of interesting time where there's this expectation that you're going to use an AI tool to get information and that it might be wrong. And so you can sort of pawn it off as, hey, we have these new insights and we want to adjust what we've been measuring. But I don't know that people are looking at 3 years of trailing data the same way and coming back and saying we're wrong.
Okay, so
maybe I'm missing.
No, but let me interpret that, which is okay. I should feel really free. I need to remind everyone that this is early days. It's very open territory, and it's okay to hit the brakes and restart. I mean, this is true with vibe coding and coding, which is sometimes you just have to throw it all away and start over.
Yeah,
okay.
Totally. Can I build off of something that Chethan just said? So you'd said something super interesting a few minutes. I mean, you've said many interesting things, of course, but one in particular was very interesting. And one of the things that happens when there's a massive change in technology is that the companies that win are the companies who don't make sort of this half step toward change, but realize the entire operating system of an industry is changing, not just your institution, right? And so I think if you're a junior person in your career right now, you can drive a truck through that. And I think that's happening right now in healthcare in a way that is unique for healthcare. I don't think it's happened in healthcare. It didn't happen when healthcare moved to the cloud, for example.
Yeah, and I'll say, I think my take on why large language models are so profound in healthcare and the potential is that healthcare really happens, the way we actually experience healthcare or deliver healthcare is in the realm of language, right? You may receive a blood test result and there's numerical things there, but you're talking to your doctor or a family member about how should you worry about this, right? The way your brain processes the information of healthcare, how we communicate it, is written in verbal communication. That is the medium in which healthcare happens. And until we've had LLMs, we haven't had computable ways of actually working with language at scale. So I think that's why it's really profound. And I think getting to your question of metrics, we also now have new ways of measuring metrics, right? Because of the power of LLMs to, you might have a metric of, you have a lot of ambient scribes. My friend Stefano is visiting here, works for an ambient scribe company from San Francisco. And right now, there's a lot of new metrics that may be possible, such as like, what was the level of empathy of the physician in the visit, right? That could be measured in ways from the language that we don't measure right now. So I think we're in a world of just, the game has changed. A lot of new possibilities are afoot.
Yeah, and to piggyback off that, I think sometimes you just have to pivot. And so, there's a startup. It's called Rune, coming out of Cornell. Really, wonderful people who are behind this. And the initial premise was, we're going to get physicians who are experts to make short form videos to educate patients, and then we're going to use an AI layer so that patients can come here with their questions. They can feel comfortable that the information they're getting is vetted. It's from providers like their own. Well, now in the past 2 or 3 years, there are so many ways to get the same information using ChatGPT or another AI for health type of LLM, that they had to figure out, okay, well, is this going to continue to be our value add? And so one of the things that Rune is doing is pivoting towards saying, you know what, one thing that AI is not going to be able to replace is community. And so now what they're working towards is, hey, can we build a community of physicians? Can we create a space where physicians can talk, whether it's about AI in healthcare or about, some article they read? Let's find a way to bring people together, bring ideas together. And so thinking about, okay, we've built this base layer. We've gotten, we've built this community of physicians. And now that AI has supplanted the original purpose of what we were doing, how do we take all that infrastructure and all that community we've built and create something really worthwhile out of it? And so I think that there are a lot of, companies that are starting to see, oh, wait, some of these ambient scribe companies may be thinking the same thing, like, oh, we built these ambient scribes, but now Epic is saying that they're going to build their own. And now, ChatGPT and Claude are getting into the game, and like they can also do voice to text in an LLM. So, how are people going to pivot, and what are they going to change as their outcome now that AI is revolutionizing things? We're watching this happen in real time because the technology is moving so quickly. And so I don't think there's a good answer for this.
No, fair enough. I mean, frankly, we're in the same boat. Like, we're building an acceleration platform, and roughly every 6 months, somebody comes with a hammer and hits us right in the forehead. Like, and it's just like, oh, well, I guess we're doing something radically different, because that set of features that we assumed were going to be a moat are just gone. And I think literally for a few years, we all have to get used to this, like just used to the fact that all the standards and all the rules and all the things that we were assuming and the metrics really might just change because some new function comes along for $20 a month that's just radically different than anyone has been able to do with a computer before. And it probably doesn't work out of the box, and it's great. Like, it's just a messy moment. So I'm just stating that as a technologist, so everybody feels comfortable talking about their own failures later in the room. So now I want to take it in a more spiritual place and just go over to money, because everything we're talking about is expensive. Everything with healthcare, everything is a financial disaster, top to bottom, as far as I can tell, I mean, as an outsider, as a layman. But I think, like, what I was thinking about is, like, a lot of things are suddenly getting much, much cheaper, and things are also still, like healthcare is still unbelievably expensive. I'm thinking about you and what you're trying to do, which is, and I'm looking at Erynn, sorry, and if people can't tell, which is to try to get, to negotiate with insurers. And I mean, look, there are companies that have audio chatbots that call insurers to talk, I guess, to their audio chatbots over a landline. And that's like how APIs work now, right? So we're in a moment, like, money is spilling everywhere. There's a huge amount of money in this industry, which to me is one of the reasons why LLMs and so the big LLM vendors are so enthusiastic. And so, like, bring it in a little bit. Like, where, a lot of people here have startups, right? And a lot of things are very chaotic, and a lot of things that are going to be really valuable to do aren't necessarily going to be profitable. And so I'm going to just pause and just like kind of let people react for a second. I know that's not a question. I'm a very lazy moderator, but just sort of take it for a second, see where it goes.
So, so with ChatGPT for healthcare, OpenAI for healthcare, that was just announced within the past week or so. One of the things that they're doing is for some of the institutions they're partnering with, it's just a 1-year trial period, and that's it. It ends. There is no plan to renew it. There is no longer-term contract. It is just you have 1 year to prove that you can make our institution more money. And you can do that either by making clinical care easier and sort of to the point of pajama time and that being a metric. The health system doesn't care about that. The health system cares if I use an ambient scribe, can I get this physician to see more patients, bill for more patients, and bring in more revenue without me having to hire more support? You know, on the operational side, can we improve revenue cycle management? And how can AI actually help us do that? You know, does it understand ICD-10 codes better? Can it help make sure that we're doing charge capture appropriately? You know, those sorts of questions. And so at least with ChatGPT, they have a limited time to prove, yes, we can actually make you more money. And at the end of the day, that's what a lot of these hospitals and institutions really care about. The trick is ChatGPT for health and healthcare advanced enough that it can actually prove that value proposition? Because say they don't actually improve the bottom line of these institutions, are they then going to say, that's it, we're walking away from this, we tried it, it didn't work? And then as the tools continue to improve next year, the year after, and the year after that, now that they've been burned, are they going to be less likely to say, oh yeah, we can find the use cases for AI. Now that the technology has further advanced, we can see the benefit to our ROI. So I think we're, you know, in this place where we're kind of at the beginning and using this as the test period, but the answers that we get at the end of this year may or may not actually be reflective of what the reality is going to be 2, 3, 4 years down the line.
I can jump in to follow up on a few points. So I think one, there is this, you know, to the point of there's a lot that's shifting. There's a feeling I have that the whole underlying game of how our healthcare system is structured is shifting in many ways, right? Where we've made things so expensive, access was so high that, and now with the big beautiful bill or whatever you want to call it, costs are going to go up further because we're further and we're further stripping Medicaid, and more people without insurance are going to go to hospitals and drive up costs, and that drives up commercial costs. So a lot of things sort of go against the existing model of healthcare is just set to crash. And now for patients, you're like, okay, I need to rely on a tool like ChatGPT for health to find information. And I think the traditional healthcare system and regulators are like, okay, they'll use ChatGPT for health to find information, but that's it. They still have to come to a real doctor for medications. Not anymore. You have Doctronic, which just a few weeks ago, now in Utah, has the ability to prescribe. Right now, it's autonomously prescribing medication refills for 194 medications. But it's the beginning, right, of actually there's Utah saying we're going to remove human physicians from the loop. And I think this is moving much faster than the traditional healthcare system realizes. There's still obviously a lot of structural things where you need to come in to get surgery and procedures. But I think we've squeezed people so much and created such a broken system that there's a lot of radical transformation that's happening and the entire game is changing. So I think that's one kind of broad point to think of. I think specifically with some of the things that I've been involved with, I mentioned the startup OpenHand. We've been building in a capital-light, nimble way. Initially started with a tool to help patients in the space of helping negotiate your medical bills, but also have kind of expanded to helping patients with preparing for visits, scribe, that kind of guides you. But we've operated in this model that's been very nimble because we didn't want to. We had, VCs reach out to us a year ago and like go all in. We're like, no, we see this landscape is changing really rapidly, and so our approach has been to kind of ride with it, do a little experimentation, find customers in different spaces, and build in that more capital light way. So that's kind of our personal building approach in this time.
Before we go on, okay, Utah, going to prescribe, no problem, got the bot in there. How do we feel about that as doctors and as antagonists of the insurance industry? Like, what do we think about this?
I just think it's a really bad idea.
Okay, why is it a bad idea? Just in
So-
case anybody here, she thinks it's a bad idea.
Happy to go on record. I'm far enough in my career that I can go on record on this. So I'm thinking, and I'm still thinking about your prior question too. So I remember actually you were in some of these meetings with me 10, 15 years ago. I was sitting in meetings here in New York City with CEOs and boards of major media companies, huge media companies. And they were looking me straight in the eye and they're like, yeah, but Facebook says if we give them our content, they will let us keep the data and they'll help us make more money. And I was looking at them and saying, they're lying. And this is not where this is going to go. I've worked in Silicon Valley since '95. And they're like, no. We looked them straight in the eye.
They were like shark eyes, but it was great. Yeah.
And I still remember. And, you know, a lot of those they're gone. Like, these companies are gone. Their people don't have jobs anymore. The people who went to them for content, for unbiased news, don't have a place to go anymore. This is a major industry that's gone because they missed something that was changing about technology.
Well, there are a lot of sad ghosts wandering around inside of private equity, but yes, yeah, they're gone.
A lot of editors in private equity.
Yeah.
I talk to them all the time. So that's one thing I'm thinking about. And then the other thing I'm thinking about is some of the data that I've seen lately that, 1 out of 6 Americans in the last 2 weeks has gone to one of the major chat systems for healthcare advice. And 43% of Americans trust a chat engine more than their own physician to get primary care advice. This just seems like a really bad idea to me. This is not something that's necessarily going to end well. So my immediate reaction is, I don't think it's going to end well. The flip side is, unless we get control of the economics, and unless we get control, and right now getting control of the economics means getting control of the AI, because to Chethan's point, it is so cheap to build stuff right now.
Yeah.
If in order to come out of this inevitable crater and build something that is human forward, I think we have to get ahead of this technology change. And that doesn't necessarily mean lining up to have bots do prescriptions, because I just think that furthers the consumerization of medical care, right? So many people right now think that medical care is you go to Roe or you go to Hims and Hers or you just get a prescription. And that's not medical care. That's a consumer experience.
Just want to build on one thing and also bring it back to New York. I think, part of what you're saying in this underlying premise with starting with media in Silicon Valley is this concentration of power and, just a few people kind of controlling a lot of flow of information. And now we're starting to see that happening if all healthcare is moving towards a few AI companies that control a lot of this. And I think there's a lot of, with monopolies, there's a lot of kind of cutting corners, and then consumers get hurt in different ways, even if it's not price. A lot of the work of Lena Khan and showing how consumer harm can happen in different ways. And I think in New York right now, I wrote this article on LinkedIn on January 1st, really inspired by the campaign of Zoran Mamdani, that is really asking this question of how do we realign these systems of technology, of power, of money, to better work for people, right? I think that, to me, that felt like that was at the heart of his campaign. And we're in this really unique moment where we have such a concentration of money and power and inequality and in healthcare, we're at this precipice where that can go in many different directions, where basically all of healthcare can just be Silicon Valley-fied for good or bad, but I think bad. And so I think New York stands in a really unique place where we have the best health tech sector and the best place for health tech based on a number of metrics and vibes. And with the combination of what Zoran Mamdani means for how we examine just the way we do things, right? It's technology is asking like this question of like we could do things differently, and now in New York City, it's like how do we restructure how things work, and raise the question of like what does a public healthcare AI infrastructure for the state look like that works for the public? So just wanted to kind of posit those thoughts.
What I'm going to do is drive forward to our third M, which actually ties in very nicely, which is what are our worst case scenarios and what's keeping you up? Because it sounds like you're thinking a lot about this. And let me come back to you. Like what is scaring you about AI, but about anything?
I think about anything is going to be. I don't think we have the time for that.
About
but
the people in this room.
Going back to this idea of Doctronic just writing prescriptions. One thing that really scares me is the loss of expertise, the loss of faith in expertise. I think doctors serve an incredibly important function. And yes, there are lots of simple questions that you can ask ChatGPT, and you don't need to necessarily go to a physician. You're exposed to someone who has a cold, and now you have a cold. Like, yes, okay, fine. The ChatGPT can tell you what cold medicine to take. That's fine. But this erosion, this idea that, there's Dr. Google, there's ChatGPT for health, like it's taking all my medical information. Of course, it's going to know better. I think that's a really slippery slope. And there is some evidence to suggest that this might be happening. Chethan mentioned the no harm study out of Stanford and Mass Gen. I have to stand up for Mass Gen being having a lot of authors on that study. But the idea was they looked at like 1,000 medical questions, and they looked at 31 LLMs, and they were saying, okay, how often is this LLM answering in a way that if you went and clinically applied it, it would cause severe harm? And there were like around 4,000 clinical decision points that were incorporated in this. And they found that severe harm, the way they categorized it, would occur in around 22% of cases. And when they delved in and they were sort of like, okay, but what is the harm? In 76% of those cases, it was omission. So this idea that the LLM will give you that quick answer back, but it's not thorough, and it doesn't have context, and it may not understand the universe in which it is answering this question. And there, interestingly, there was a New England Journal article, sometime in the fall, where they talked about, using LLMs on the wards and how they anticipate this degradation of expertise and medical knowledge. Because, if you're a resident and your attending is going to pimp you, you're just going to look up that one answer. Whereas what we used to have to do is go to the online encyclopedia, read a review article, go to the library, that kind of thing. And when you do that, you're not just getting the answer to your question, you're getting all the context. You're actually learning, oh, this is the science behind this. This is the reason this disease is happening. This is why this treatment works. These are all the different edge cases where if I see this next time in a slightly different presentation, I'm still going to recognize it as the same entity because I have that knowledge. With things like ChatGPT, people aren't learning all of that context anymore. So they're going to see the same patient with a slightly different presentation and maybe not recognize that that's what they're seeing. And so right now, I think doctors have, they serve this role. The pattern matching that we can do, the recognition of someone being sick or not sick, our understanding of the disease course, I think is really critical. I don't think that LLMs will be able to replace us. I do think they'll be able to augment this work. Even in radiology, where they've been using AI for like a decade now, the radiology match was still close to 100%. So people are still going into these fields. They recognize these jobs are not going away. But I worry that there is this public perception that we don't need these doctors. They're not really that helpful. And I also worry in terms of medical education, people aren't going to be educated in the same way because they have such easy access to answers from these AI tools.
Card catalogs were really good for context. Yeah, the Dewey Decimal
That's right,
System. Yeah, exactly. I think we're. Wait a second. I have to give context before I say this. The context is if you drive around any town in New England, raise your hand if you've driven around New England. The tallest building in town is always a church, and there's a reason for that. And the biggest house in town is always the old doctor's house, because the doctor was the center of community, and the doctor was the center of everything that happened in town. Not only the money, but also the social life. Like everybody went to the doctors, right, after church, hang out, have a Sunday social. And when I think about what I'm about to say, like I think we're going to see a massive crash. We're going to see two crashes happening at the same time. We're going to see an investment crash in AI. At the same time, we're going to see a crash in healthcare, because healthcare is just too expensive for people to pay for anymore. And so at the same time we see that crash in healthcare and that crash in investment, what you really affect in that kind of mess is institutions. So you'll see it affecting hospitals. But I think you won't see it affecting primary care physicians in the same way. And I think there's the possibility that primary care physicians can step into this vacuum that's going to be created. Most people, most of the time, are healthy. Most people, most of the time, don't need to go to the hospital. But most people need once in a while to go to their primary care doctor. And if the primary care doctor has an alternative to providing care and reaching patients rather than going through a hospital, which is no longer funded because their PE money just ran out, I think we have the possibility of some really interesting things happening.
I want to start before getting into the mess. Sorry about leaving Mass General out. And actually, part of why I think New York is the place for health tech. It's not just New York, it's the Northeast corridor. It's the ability to stitch from DC, Baltimore, Philly, New York, New Haven, Providence, Boston, and all the institutions. And one of my long-term dreams, and maybe we can work on this together, is to rent out an Acela. We're gonna have a conference on the train. It's called Accelerate Health.
We can just do it in the quiet car and just see what happens. But
I think going to the doctronic case of prescribing, the way it's framed is that we're picking 194 medications that are considered low risk, and they're not controlled substances. I think that carving out of things, and I think this was to your point, Kamal, like that's kind of the slippery slope, right? It's the erosion of expertise, and it's also saying like, oh, getting your antihypertensive medication refilled or your cholesterol medication refilled, it's not a big deal. But there's a lot that's kind of implicit in that. When you go for a medication refill, on the one hand, yes, sometimes there could be annoying friction. You have to schedule an appointment and call. But by going to the doctor and engaging with it, you may actually start to talk more about it and say, hey, taking this antihypertensive medication, maybe you're someone who lives in a hot climate like Phoenix, tying into my climate change work. There's a lot of antihypertensives increase your risk of heat-related illness because, like diuretics, they cause you to pee out more, right? So there could be subtle things that are related to your medications that oftentimes when you go for a refill, like getting a refill and the annoying friction is the thing that drives people to go to the doctor, and some things may come up that were otherwise missed. And if you just say like, okay, let's remove all the friction, like, most people don't like going to the doctor. You don't want to go, right, unless you really have to. But those are times in our life where it's annoying, but then something may come up because of it. And so by saying like, okay, these are pretty common medications, and this is not to say like, Doctronic, the way they frame this is that they are a AI doctor that's thoroughly evaluating a lot of these, symptoms and other things that might happen. It's not just rubber stamping it. So I think it's still to be seen how that plays out. But I think the idea of just carving out certain parts of care and saying these are simple, we can have, AI that doesn't necessarily like have, that still like needs to prove itself, I think is a slippery slope. And the last part of it, I think getting to the core function of human physicians right now, there's the connection. I love the story of the church and the house and the true like partnership and care that can happen. But I think the piece we haven't talked about right now is the legal side, right? Most human physicians are taking on a lot of legal risk with the decisions we make. I think a Doctronic example, it's a unique model where I think the state of Utah plus Doctronic are taking on legal risks together.
They bought insurance together too.
Yeah, and so I actually think we need to see more innovation in legal risk models, because we sort of have all or nothing models right now where human physicians take all the risk. And when you think about AI being implemented, whether it's like an AI clinical decision support tool or other AI tools, AI developers don't generally want to take on malpractice risk. But then you get to this sort of all or nothing, situation. And then for clinicians, we're taking on more and more risk. And then also if you look at physicians and other clinicians employed by hospitals, generally your hospital, they're not taking that risk on with you. Like if, for example, if I use a scribe tool, and maybe this is not, another AI tool, and I didn't catch an error that it made, that is all on me. That is not on my hospital, even though they vetted this tool, right? And a lot of examples show that a health system will throw a clinician under the bus because we're pretty easily replaceable. And so there's all sorts of different kind of fault lines in risk, and we need more innovation there.
When you mentioned Phoenix, my brain immediately, I went to demo our product at this enormous hotel. And actually, when I opened the window in the morning, there was a water slide. So I was like, this society is going to die. But, so I gave my little talk, and then I walked down the hall, and I go into the really big room. And it was, I think, Damon Dash from Shark Tank. And all he was talking about was how he talked to ChatGPT about his baby aspirin. And it told him he didn't need to take it anymore. And he was great with that. That was amazing. Like his doctor kept saying he had to take baby aspirin, but ChatGPT didn't. And that was it. Like that was his entire scientific process in deciding he no longer needed baby aspirin in his life. In that moment, as he told that to 1,000 people from the stage, I was like, we're in trouble, right? Like this is actually, like we're not ready for this. Like this is a very successful human being who, and Americans just love to be smarter than their doctors. It's like our national pastime, right? And we've given them a super tool that lets you be smarter than a doctor or pretend to be. It's like a role-playing tool to be a doctor yourself. And so I think it's like that one is just going to be a long time, and there's going to be some really bad stuff that happens as a result. And so I'm really glad you're bringing it up. Like I mean, at some level, I see these things as incredibly exciting puzzles because you can't stop culture from being culture. But and the other thing I think before I get to the last M, is that we're going through this moment. And what I'm noticing, because I'm in New York, and I'm surrounded by lots of progressive people, and I'm seeing a connective tissue emerging around activists that hasn't been there for 20 years because our society is just truly going through it. And I don't really need to explain that, right? But I think that you're starting to see the same thing, right? Which is just sort of like people don't know why that friction's there. And they're going to need to be taught, and they're going to need to learn that the outcome will be better if they accept some friction in that they do need to talk to the doctor, and they do need to learn about probably the practice is going to need to explain a little differently and actually bring them into it and be like, this is why you don't just want to get that off the chat, right? And I think we'll see some new dynamics emerge, but the legal issue is, my God, I don't even touch that.
But also what technologists call friction is almost always just two people talking to each other.
Yeah.
Which I think we can all agree is maybe not bad.
That's why we're here, Erynn, in New York City at this is a technology event where we're talking. No, this is real, right? Like our product is tricky because we're former agency people, Rich and me, and so are many of the team, and we actually assume that really simple stuff will be more and more solved by this stuff, but complex stuff, and I'm as deep into vibe coding, like kind of as anybody alive right now. Like I know that, and you hit a wall, and it's a hard wall, and it's a wall it's the product wall. Like somebody has to decide who this is for. Like an architect can build a Burger King, or they can build like a museum, and it's the same kind of work, but the output is very, very different.
I just wanted to add a really quick other mess that I think we have to be careful of. I recently just taught a course on generating real-world evidence from real-world data to executive MBA students, and we spent a whole day talking about synthetic data, right? We have this whole world because, for people who are developing AI models and other tools, it's actually pretty hard to get real actual data. You have to go through IRBs. You have to find all these partnerships. It costs a lot of money. It's so much easier to just generate synthetic data and then build a sepsis model off of it, right? And IRBs are now saying if you're using synthetic data, you don't even need an IRB anymore, right? So there's a whole Nature commentary on the perils of synthetic data in healthcare, and I think we are not ready, and I'm actually very scared.
No, one thing you're going to find over and over, and we're finding, advocating for the relationship becomes almost like a political position. Like you need humans to look at this, and the actual success of the software for us will be determined by an individual deciding they want it. And it can't just be people putting one robot putting something in a box and another one taking it out.
And that's why New York is better than San Francisco.
100%.
We love that
We
stuff.
love our people.
We drink too much.
We have unions.
Um, we do. All right, so the last one, and it's a short one, and then we'll open up to questions. But just who's somebody who's doing something well, and or a newsletter to read, or just something that like you'd like this room to know more about, something that you think people should pay more attention to. There, you're right there. I'm sorry you sat on this part of the sofa.
Me too. Let's see. I think something people should be paying more attention to. I think it's interesting. I think the use of AI agents actually is going to be very interesting. So Hippocratic AI, which developed AI agents for all sorts of things. Like your patient's discharged from the hospital, someone needs to call and follow up and see how they're doing. And Hippocratic AI has a little AI agent that will call them and sort of triage and make sure they're doing okay, and then kick it up the line if they need more help. And they just bought another company, I think Grove AI. So they're looking to go into clinical trials and biopharma and sort of extend the reach of this. And sort of like we were talking about, like the friction of, I don't want to call my doctor, and I don't want to have to deal with scheduling, and I don't want to do all that stuff. But if there's an AI agent that can help with all of that, and it makes it really easy and it takes the friction out of the process, is that going to mean that it's going to be easier for us to get healthcare, get to the good part, get to the things that we should be doing? So I would say watch this space when it comes to AI agents in healthcare, and I think I'm really excited to see how that evolves.
I have three. Dr. Paulius Mao out of Boston do you know him too? Yeah, XPC. He runs a really interesting Slack group, mostly physicians talking about AI. If you're a physician,
Wait, what's it called again?
XPC.
XPC.
It's like solve for X.
Okay.
Yes.
Good luck,
It's
everybody,
way
with that.
better than that sounded. Find us if you want to. It's an amazing group to be part of. The second, I'd be remiss if I didn't call out-of-pocket health and the work they're doing to democratize access to information about the healthcare system for business people to drive innovation. It's an incredible project if it's not on your radar. And the third is a guy named Carter Dredge. I don't know if anybody here knows who he is. He's an economist out of Utah who's done some really interesting work at Harvard, then Cambridge, and now in Utah around changing the economics of healthcare and taking advantage of technology shifts to do that. He just drove a project with Intermountain Health to develop a whole new suite of pharmaceuticals that were priced so low that they actually had to artificially raise the price of some of them in the catalogs because the hospitals weren't trusting them, that they were actually developed here in the United States or produced here in the United States. Formularies were here in the United States. So those are the three: Carter Dredge, Out-of-Pocket Health, and Dr. Paulius Mao.
Because you did three, I'm going to do four. Sorry. There's some personal. So, I think the work we do at Cornell Tech in New York is really about being the space to have all these conversations, right? It's an academic institution, but really designed to support the connection to industry, part of the vision of Michael Bloomberg when he was mayor. And so we bring together all of these different facets, from people building startups to the deep research and safety and legal and tech. And a lot of my role is making sure that clinicians at Weill Cornell and New York Presbyterian are part of it, but not just Cornell. And the mission of Cornell Tech is not just to support Cornell, but really grow the economy of New York City. So no matter what institution you're part of, we're part of kind of supporting that. The work I do with Open Notes is a research group based in Boston at Beth Israel Deaconess Medical Center, one of the Harvard teaching hospitals. Been around for 15 years, really advocating for patients' access to their notes or transparency. And I helped to launch the Open Notes Lab 2 years ago, really looking at how, as these different AI technologies enter clinical practice, how do we make sure that we're maximizing the benefits for patients directly? So want to mention that. Number three, this was a group I got to visit while I was in San Francisco for JP Morgan. Just learned about them recently, the Noesis Collaborative. Really cool group of a lot of pioneers in AI and tech research. Many people who have worked at companies like Meta, big tech companies, and felt that technologies have caused a lot of harms in promoting teen depression to political instability around the world, and who are really committed to ensuring that we don't make a lot of these mistakes with AI again. Really cool group. And then the last one I'll mention is There's an organization based in Europe called the Health AI Agency. I think I'm forgetting the exact name. It's like Global Health AI, but it's basically this regulatory group for countries around the world, because this is like I think we're largely talking about in the US, but Health AI, the idea of, I was invited out to the Philippines a year ago to talk about the potential of Health AI, where you can bring specialist care to remote islands that have no doctors. The transformative potential of Health AI is tremendous globally, and this Health AI, I think it's healthai.agency, what they're doing is they're working with high, middle, and low-income countries to help countries create regulatory frameworks together. It's the CEO right now is a physician, who's a former member of parliament of Portugal. And so I think they're doing some like really great work in building capacity globally for us to advance Health AI in a safe way, but also learn from each other.
All right. Oh, no, go. You've got some more.
Okay.
Yeah.
Just because they did 3 and 4, I feel like I should at least do 2.
Because you went first.
Yeah. So one last thing I'll say is, so I used to work for the federal government. And yes, fantastic. And it doesn't seem like the federal government is putting a lot of guardrails in AI right now. That could be good, that could be bad. But when I worked for the government, one of the things I realized is that the government can only do so much. It can regulate, it can give money, and there are certain places where it can take action. But most of the action is taken by people like us, people in this room, the startups, the founders, the people who are working in this space. So what I would suggest is take this as a call to action, that you really need to think about how you want healthcare AI to function. For you, for your parents, for the people who are going to end up receiving care. How do we build systems that function in a way that will actually improve the health of our population over time? We're sort of at this inflection point, and there aren't a lot of guardrails. There's not a lot of guidance. And so the people in this room are the leaders in health AI in New York. And so we really need to be thoughtful about what our approach is going to be.
Great. So look, first of all, I just want to say thank you to our panelists. We're going to take some questions. Yes. That was, I swear to God, the easiest moderating. I've moderated a lot. That was very easy. Just silk. Just my God. So thank you. Thank you very much. Let's take like 2 or 3 questions, but really like this room is set up. There's still snacks, and like we'll be around for a minute. And so if anybody has anything burning, please lift a hand. And oh, you're shy. Oh, there. Please, loudly though.
Thinking about a lot of you involved in like AI in current clinical practice. If you're to go back and you're in residency today, how would you approach your medical training?
I would cheat all the time. I would never read a textbook. I would ask ChatGPT every question. I would cheat all the time, which is why I have to be on top of my residents and make sure they are not doing that for their own good.
Yeah, it's a really important question. There's a really great article in the New Yorker by Dhruv Kular, who's a physician at Cornell and writer, journalist. He wrote this. I think he has a lot of great pieces on AI, but it's I think the piece was specifically if AI can diagnose, what are doctors for, and he interviews a third-year medical student who's on his clinical rotations, and I think you mentioned this point of how you're preparing, and the student said they realized at first they're using AI tools like Open Evidence, Doximity to
DocsGPT.
DocsGPT.
Gotta plug it.
Yeah. I use both. DocsGPT to like prepare for presentations on rounds. But then the student realized after a week, in this article he said, I realized I did not form a single original thought of my own, and I felt dirty about it. And then the student challenged themselves to not use any AI tools for a week. But it's kind of that individual reliance. But I think we actually need to create, I actually think this is part of a broader symptom, which has been a long-standing problem, that medical education emphasizes the wrong things. It just emphasizes memorization, and I think part of this is a more radical shift where I think with AI tools, right, there is so much information out there. It's hard to keep on top of everything. The hope and vision is that doctors are using AI tools to learn the latest research and kind of prepare things in the best way possible. Patients are using their own AI tools to optimize and prepare for the visit. So when you're having conversations, it's just much more high level. I'm going to get super nerdy, but does everyone here know the DIKW pyramid?
Yeah, you might need to break that one down just a little bit.
Really important concept. Also, for my I was fortunate to do a fellowship in clinical informatics and learn this, but one of the fundamental concepts in informatics is the DIKW pyramid: data, information, knowledge, wisdom. It's the bottom. You have data that turns into information, wisdom, knowledge, and wisdom. Right. A lot of medical visits, we're kind of really at that data and information place. We're just talking about like how long have your symptoms been going on for? Tell me about it. Like, we don't really get to that knowledge level, and so part of the hope is that with AI tools that we can get better preparation, that the human connection that happens really will be more at that knowledge and wisdom level, where human connection matters.
I'll also just say that this is like being human. Like, humans always want the easy way out, whatever's easier, whatever's convenient. And so it's difficult to go against human nature and to try to get med students and residents and be like, no, you got to eat your vegetables, because one day you're going to be making this decision. And if you haven't made it 1,000 times before, it's going to be really hard for you. You're not going to trust your own judgment, and it's going to be hard for your patients to trust it too. This is part of your training. And so,
Then you can just go to ChatGPT as your therapy bot, and it'll make you feel better about yourself no matter what you do.
Am I using LLMs too much, right? And then it's like, no, you're doing good.
That's a great question.
Please, you're right there and then right there. Okay.
The discussion I found was reminding me of conversations I had a long time ago with typographers about desktop publishing, and with cartographers and caddies about GPS. And I guess that my overall thought is those conversations, those experts were technically correct, and yet in some larger sense, they kind of missed the point of where we wound up. And I'm just curious whether it's possible that you are collectively too expert to see where we're going to wind up in the medical space.
Yeah.
Actually, I live in Newport, Rhode Island, so I know a lot of typographers, ironically. And also, like, I've heard this example, right, of the cabbies and before and GPS. And you know what happened in London, right, with the cabbies there? Does anybody know about the test? Literally, it's called yes. It's the hardest test that anybody has to take to get a job, and you have to take it to get a London cabbie. And notably, Uber and Lyft were run out of London in favor of these London cabbies a little while ago, right? And I think it's because they caught, and this was something we were talking about earlier, they understood that what was changing was the operating system, not necessarily the products. So you can think about the type available on a word processor as a product. But that relationship of trusting somebody, like I worked for Drizzly, we sold to Uber, I saw the data around how, trying to think about how to say this in a way that could be printed. It was printed today. Uber has had a lot of problems with sexual assault of women in their cars. I know this. I'm going to take a cab anytime I'm in New York City before I'm going to hop in an Uber, right? And I think that there's a place where you have to accept that the economics of something are changing, and then figure out how to get in front of that economic shift and then preserve your position. What failed in New York is the cabbies failed on the medallion issue. That's where they failed on the economics. That's not what happened in London.
Yeah, I really love the question, and yeah, could be totally right. Like, there's so much we don't know of where things are going. And I like the two examples you pointed out, because I think building on GPS, I think it's a great analogy, right? We're maybe less good at reading maps and navigating, but at the same time, there's a whole new world of possibility. Like, I could fly to a city I've never been to before and get to a coffee shop based on its ratings. And so I'm able to explore the world a lot more than I ever had been before without having GPS, right? But I'm maybe less good at reading maps on my own. So new possibilities that weren't imagined before. I think the typography example, what that made me think of actually, it's as we transition from like the very artisan human craft into things that become more technological and remove some of the like human kind of intricacies. It made me think of the story that Steve Jobs shares in the Stanford commencement speech. That's pretty famous. He talks about how, you know, when he went to Reed College, and you know, he audited a calligraphy class, right? And that was really important for him in the early days of Mac, to actually have fonts. And it was the first, I think it was this element of like bringing more humanness into the technology we create. And you could argue that, you know, did that really matter in that era? Like Windows really dominated, but I think that ethos then carried over to the phone era, and you could, you know, I think it's hard to argue that the iPhone did not kind of dominate the early smartphone wars. And I think it goes back to some of the ethos that came from the Jobs days of keeping humanism and design in technology as we translate things and advance.
Before Jobs did that, there was only one font available. And I would argue that desktop publishing, which was the driver behind the PC, took off because there were multiple fonts associated with it, right? I don't think we would have had the PC revolution without multiple fonts.
Fonts are important. Actually, interesting. Well, actually, the whole story of open notes actually started because of typography as well. Back in the day, doctors wrote notes by hand. You could argue that doctors don't have good handwriting, but some do. And Tom Delbanco, who's the founder of Open Notes, old school internal medicine physician in Boston, he was taking care of a patient who had issues with alcohol abuse. And he was writing, you know, we keep meeting and patient is still not making any changes, or something to that effect. This patient is reading everything he's writing, and he's able to read upside down because he was a typesetter. And that led to this moment of insight. The culture of medicine used to be one where the notes that doctors write, this is not for patients. This is for communicating with other clinical colleagues. But this was in the 1970s. Dr. Delbanco, his insight was to turn the page around, give it to the patient, told him to read everything you wrote about him, which was not very flattering. And that the patient then shared, like, it was painful to read, but reading this, like, I understand, like, I understand why you're telling me in a way that when we were just talking, the message didn't get through, right? So it's bringing in that transparency, and that's been part of the whole mission of Open Notes, but it all started with a typesetter.
Great question.
Let's do one more question.
Well, deny you care. Deny you care, which is worse.
Well, I think I could sorry. Yeah, I think you're raising, you know, I think at the heart of your question is this idea that, you know, there's a lot of AI tools that are coming in for convenience, and it's not just convenience, but it's really at the heart, and what you're describing are ambient scribes, which are one of the most kind of well-funded technology right now, because they're able to listen to human conversations and capture key details. But then what you're getting at is, like, depending on who gets that information, you could optimize it for different things, right? So if you're a healthcare system, you may want to optimize it to bill more money from insurance for this patient. If you're an insurance company, you want to find a reason to not pay for something. And yeah. So we're getting to this arms race, right? Where, you know, in healthcare, there's this, in the U.S. healthcare system, we have this triangle. You have healthcare providers like doctors, payers, insurance companies, and patients/employers, because a lot of people get their health insurance from their employer, so it's patients/employers. We have a lot of AI tools that are really empowering the providers and payers, much less so in the patient kind of employer space. That's kind of one of the places where I've been really excited about and kind of building. I think that's where, you know, we're seeing companies like OpenAI, but I think we're getting into a world where everyone in this triangle has their own AI tools. But then it's all about like what you're optimizing for, right? And there's a really, really good paper in the New England Journal of Medicine AI called Artificial Intelligence and Human Values by Zach Kohaney, who's the editor-in-chief. And he talks about this case of a 8-year-old boy with short stature who may be eligible for growth hormone therapy. So you're seeing, and with growth hormone, so growth hormone is very expensive. It's a treatment you have to take frequently. And so there's some kids who definitely need it. It's very clear they need it. There's a lot of kids who fall into a gray area of criteria that they have to meet, that pediatric endocrinologists. When I started my pediatric residency, I thought I wanted to be a pediatric endocrinologist. And one of the newer attendings told me, don't do it, because 50% of your time is spent arguing with insurance companies about growth hormone. And also you make much less money than being a general pediatrician. Another very broken thing is we as a country do not care about children. We just don't pay for children's care. It's a whole another soapbox I can get into. But to this paper, right, it says it has the exact same case. It has the exact same clinical facts of this 8-year-old at the 10th percentile for height for their age, and basically asks, should this person get growth hormone therapy? And what they do is they prompt the agent with the exact same data. The only thing that changes is the persona. So it says, you are a pediatric endocrinologist. Here's the data. Should this patient get growth hormone therapy? It says yes. But if you say you are an insurance company representative, exact same data, should this patient get growth hormone therapy? It says no. Right? So it's like there's all these optimizations, and that's not even based on the objective data. It's literally based on the persona that you shift in the prompt.
I will say for some of the ambient scribes, they do make a recording in the background and they do make a transcript, but then what they're producing is the note. Some of them are also producing billing. Some of them are also producing an after-visit summary that's in patient-friendly language. And then they delete the original recording and the original transcript for the most part. And so there was actually, I think it was a perspective in the New England Journal where they said, we shouldn't be deleting this because there's so much good information in there that we could learn from at a population level. And so this is sort of like an ongoing debate. The other thing that we're seeing is there's a lot of work right now. Claude for healthcare announced that they were doing it. I wouldn't be surprised if ChatGPT for healthcare is doing it too, where they're actually creating systems to fight prior auths for you. And so there's a lot of AIs that will just handle that paperwork on your behalf. That sort of like the second the prior authorization comes in, it's already ready to go. So Claude for AI is advertising they have all the ICD-10 codes, but they also have the whole list of what CMS's coverage policy is. So at least for Medicare and Medicaid, and probably managed Medicare and Medicaid as well, they can say, no, you listed on your website that you were going to cover this. Here's the evidence, so on and so forth, and they can submit that prior auth back. When I was working in the government, Medicare and Medicaid actually pledged that they were going to switch over to electronic reporting systems, and they were going to try to shorten the timeline for prior authorization to 24 hours for urgent requests and 48 hours for non-urgent requests, and that they were going to force people to submit electronically so that no longer are you like sending a fax back and forth or, all of these things. It can just be done digitally. So there's a lot of ways in which number one, like that kind of information is still protected. These AI companies, these scribe companies, have been thoughtful about, we don't want that transcript to get out, and so we are gonna set guardrails. And then also in terms of dealing with insurance companies, nobody wants the insurance company to win, and so there's a lot of companies that AI companies that are trying to find ways to fight back against prior auths, reduce that friction, and make it a lot easier for the patient to get the treatment they need at a cost that's covered by the insurance company.
You look like you're trying to decide there.
I have so much on this topic. I have written extensively. I've
You
spoken
get 1
extensively.
minute so people can eat all the cheese.
Emme the company I run now started out as a birth control adherence company. I bought it because it was a PE firm that was going to buy it, and it was the only major period tracker and birth control tracker that had never sold its data. I have run systems with hundreds of millions of daily active users. I have built and run some very, very large systems. I know what happens with that data. I know how it's stored. I know how it is not deleted, even in the best of intentions, and I know how it surfaces later. And I just didn't want that data being used for unexpected purposes. Even if that data wasn't used to specifically find out somebody who had submitted their data, it could be used to train models that could inform other people's healthcare. I didn't want any of that to happen, right? So that's my starting point. So I do not have a short answer to this question. I will say, however, and this is probably a better note, that I got my gynecological care in my 20s and 30s, and all those records were kept on paper. And my doctor's office burned down in 97, and I could not be more grateful, right? I have 3 daughters in their 20s, and I look at them, I'm like, wow, I don't know what to tell you.
So arson is the answer. That's great. That's really
But I think this risk of like your health data. I think ever since there's been a lot of very real risk, particularly since the Dobbs decision that overturned
Totally.
Roe v. Wade. Right, you now have situations where a woman in Texas may travel to California to get an abortion, and they travel back, and because of Texas's bounty law, the front desk staff can see that you got care in California, and they could actually, and this happens, they call the cops on you, right, saying that you could be arrested or worse. And so California, for example, like I know at Stanford, they actually had advice for women traveling from Texas and other states that just don't have the same health care as other states anymore. They actually told them to turn off access to the HIE. Basically, you need to opt out of health data sharing, right? So we're now in a world where like states have different levels of care. There's different legal implications for your information and the risks that places you at. A lot of people, in visits with ambient scribes, you might end up inadvertently talking about someone's immigration status. That could come up, and it could be in subtle ways. It could be like, oh, like you just traveled here recently, right? And it may not necessarily be structured data, but now current ICE, DHS could say, and the thing about HIPAA is if you're the subject of legal action, HIPAA doesn't apply, right? So you have states like Texas that are suing Seattle, trying to get the records from Seattle Children's Hospital. New York has shield laws. You have doctors in New York who provide abortion access to women in states where it's not available, and those states are going after doctors in New York. And so you have organizations like the American Medical Association, which has said states that prosecute physicians for providing, like Tennessee will prosecute a physician for providing a life-saving abortion. Even if you do it to save the life of the mother, you can still be charged with a Class C felony, right? So the American Medical Association, not the biggest fan of them as an organization, but I feel like they did take a strong stance in saying, which I really appreciate, we will not hold meetings in states that are, anti-physician, anti-women. And so we have to keep this in mind too. I feel like this is not really I feel like it's not been front and center enough of how dangerous of a country we're operating in.
Yes, I mean, this is real. It's wonderful to talk about gadgets and new technologies, but one of the reasons to have this conversation here is that a lot of people in this city want to work on that problem, right? Like it's a special place that way. Like it's exciting and motivating to just address this in all of its ugliness and then figure out where the technology should and should not be. I think that's we talk about relationships a lot, but that's the puzzle. And so open that conversation to the floor, and please help yourselves, have a little wine, relax. I will close, we got like an hour, I think. Not even a hard hour, but I got to start putting chairs away. 29 chairs, there's one missing. And it was lovely to have everyone here. We hope this is the start of a thing. Erynn has lots of ideas. I hope you will come back and visit us. And we're very, very grateful for your time. It's valuable time. Thank you very, very much. And so please, a big round. There you go. Agreed. All right, so make yourselves at home. We're glad you're here.